So, good afternoon, everyone. I hope I'm perfectly visible and I tried to increase the volume as well. So, we have increased the volume. Some students was saying the volume was low, so I did some setting changes. I hope this time it's better. So, today we will be starting with our second last lecture, and we have compiled three topics together to save your time as well. So we will discuss renal system, in which we will discuss diuretics and ADH hormone. We will discuss all the heart diseases like hypertension, heart failure, arrhythmias, heart failure. And we will also discuss blood disorders like antiplatelet, anticoagulant, thrombolytics, chelators, iron preparations, etc. Okay, so if you have any doubt, do comment on Instagram, or there is a closed Facebook channel with the name of Dr. Ankit Pharmacology series with all the medicos. It's a closed group for all medicos, and we only talk about medical science, nothing else. You have already joined Telegram group. That is why most of you students are seeing this lecture, and this is the YouTube channel in which this live streaming is occurring. And if you want to see the video, when you will share with your friends, or in future if you want to see the video, simply tap on this link or you can scan the code below. Okay. You can better, if you have any doubt, you can text me on Instagram. That will be a best way. Instagram DM kar dena. Okay. So message me. Many students are already messaging me about any doubt, any schedule. So I'll reply there. Okay. Or you can go to Facebook group as well. So let's start with our journey. Let's start on our journey of cardiovascular system. We'll start with renal system first. So which diuretic inhibits sodium potassium 2 chloride symporter? So the answer of this question is loop diuretic. So the answer of this question is loop diuretics. Okay. So remember, we have various diuretics which will act on different part of nephron. Suppose this is PCT of nephron, loop of Henle. This loop becomes thick, which is known as thick ascending limb. Then we have DCT, and lastly we have collecting duct. So remember, the first diuretic that act on PCT of nephron is carbonic anhydrase inhibitors, and a very famous drug we have in carbonic anhydrase inhibitor we have is acetazolamide, which will act on PCT of nephron. Then we have the diuretic which will act on loop of Henle. The diuretic that act on loop of Henle is osmotic diuretics. And remember, a very famous osmotic diuretic name we all know, given in cerebral edema or increased intracranial pressure, is mannitol. Then we have a diuretic that will act on thick ascending limb, of nephron, and the diuretic is loop diuretics. And loop diuretic, they inhibit one transporter on thick ascending limb, that is sodium potassium 2 chloride transporter. Okay, sodium potassium 2 chloride transporter. Then we have a diuretic that will act on DCT. So on DCT, remember, thiazide diuretics, they will work, and they inhibit one transporter known as sodium chloride symporter. Lastly, we have a diuretic that will act on collecting duct. And on collecting duct, we block the action of aldosterone hormone, which will lead to sodium loss, but potassium will be spared. Potassium sparing diuretic like spironolactone, amiloride, they will act on collecting duct of nephron. Fine. So the answer of this question is furosemide loop diuretic. So can you tell me potassium sparing diuretic they will act on aldosterone receptors which are present on collecting duct of nephron. They block aldosterone receptors. Fine. Now, the next question is acetazolamide, which is a carbonic anhydrase inhibitor. We know It's a carbonic anhydrase inhibitor. So in which fashion it inhibits carbonic anhydrase enzyme? Remember, it's an important question. It is a non-competitive plus reversible inhibitor of carbonic anhydrase enzyme. So a very unique mechanism because most of the non-competitive blockers are irreversible blocker. Exception is acetazolamide. It is a non-competitive but reversible blocker. Fine. So acetazolamide can be used in all of the following except. So let's write the uses of acetazolamide, which is a carbonic anhydrase inhibitor, is game, plan. These are the uses. So carbonic anhydrase is the most abundant enzyme in our body. It is not just present on kidney, it is present on all cells of our body, especially in eyes. We discussed it is given in the treatment of glaucoma. It is also used for alkalinization of urine because it will lead to bicarbonate loss. And if there is bicarbonate loss in urine, can we say in blood there will be acidosis? Because there is acidosis, it will stimulate respiratory centers. And it is given as a drug of choice for the treatment of mountain sickness because there the patient suffers from respiratory depression. It is also given in epilepsy and it is also given for periodic muscle paralysis, which occurs because of hypo and hyperkalemia. So these are the uses of acetazolamide. Remember, acetazolamide is absolutely contraindicated in cirrhosis or liver disease. The reason is acetazolamide increases ammonia level in blood. And you know that if ammonia level is increased in case of liver failure, it will not be converted into urea. And this ammonia can damage brain. So it can lead to encephalopathy. That is why we don't give acetazolamide in a patient of liver disease. Ammonia level increases in blood. So how it increases, we have discussed in great detail in regular theory lectures you can see on this YouTube channel or prep ladder. So regarding furosemide, the true statement is, so remember furosemide does not act on PCT, we know it acts on thick ascending limb. Remember, it is the most effective diuretic we have. It is the most effective diuretic we have, loop diuretic. That is why it is known as high ceiling diuretic. And remember, it loop diuretic loses all iron. It loses all ions in urine, whether it is sodium, calcium, magnesium, potassium. That is why it is given in the treatment of hypercalcemia in blood, hypermagnesemia in blood, and hyperkalemia or potassium level is increased. Now remember, loop diuretic furosemide, it is the drug of choice. It is the drug of choice for acute pulmonary edema, which is also known as acute left ventricular failure. Because in left ventricular failure, the blood will be collected in lungs, which will lead to acute pulmonary edema. Okay. So the answer of this question is A. Next question. Furosemide should not be administered. So loop diuretic, remember, they should not be administered with NSAIDs. NSAIDs are non-steroidal anti-inflammatory drug like aspirin. The reason is, remember, loop diuretic like furosemide, they increase prostaglandin levels. They increase prostaglandin level and prostaglandin produce vasodilation in kidney. Vasodilation in kidney will lead to increase in GFR. Increase in GFR will add on to their diuretic effect. So why we should not why we should not give with aspirin, because all NSAIDs like aspirin, they will decrease prostaglandin synthesis, opposite effect of loop diuretic, which will reduce the effect of loop diuretic, which will reduce the effect of loop diuretic. So remember, all NSAIDs like aspirin, they have anti-diuretic effect because they reduce prostaglandin synthesis. So the answer of this question comes out to be B. Okay, it's a tough question. It was asked in your NEET exam. So diuretic of choice in renal colicky pain, it was a last year question due to renal stone. The answer of this question is thiazide diuretic, and you can see thalidone word is coming. It is a type of thiazide diuretic because thiazides, they lose, sorry, thiazides, they preserve calcium. Thiazides, they preserve calcium or they inhibit calcium excretion in urine. Now, can we say if calcium is not excreted into the urine, can we say it will reduce the accumulation of calcium in urinary tract? So they will inhibit the deposition. It will reduce the deposition of calcium in urinary tract. That is why it will inhibit the formation of renal stones. ठीक है? Amruta ji, when you will give acetazolamide, remember it will increase H plus ions in blood. It will produce metabolic acidosis. And in acidosis, respiratory centers, they stimulate. In mountain sickness, because of hyperventilation, there is respiratory alkalosis, which leads to respiratory depression. To counteract this respiratory alkalosis, when we give acetazolamide, it will produce opposite effect. It will produce acidosis in mountain sickness and the person will start breathing again. So which thiazide is safe in low GFR condition or renal failure? Now remember, in low GFR or renal failure, the drug of choice is not thiazide. The drug of choice is loop diuretic because we have discussed loop diuretics, they increase GFR. That is why they are the diuretic of choice in renal failure. But with this loop diuretic, we can add one thiazide diuretic, that is metolazone. So which thiazide diuretic is safe in renal failure? That is the only thiazide metal wala drug, metolazone. Okay, it was a very frequently asked question. Fine. So thiazide diuretics can be given in the treatment of all conditions except. Now thiazides, they are good for osteoporosis. Why? Because they preserve calcium. So if calcium level in blood will increase, where this calcium will deposit? Calcium will deposit in bones. So that is why thiazide diuretic, they increase bone mineral density. So if a patient is having osteoporosis, especially old age patient who suffer from the risk of osteoporosis, in old age people we prefer to give thiazide diuretics. Now they are given in the treatment of hypertension. Yes, they are the diuretic of choice or the first line drug for hypertension. They are also given in the treatment of diabetes insipidus because in diabetes insipidus, thiazide diuretic, they become anti-diuretic drug. They become anti-diuretic drug. The reason is in thiazide diuretic, remember there is excessive water secretion into urine because ADH hormone is not working. When you give thiazide diuretic, they reduce water excretion into the urine. This statement can be written as they reduce excessive water excretion in urine. We call it as they reduce positive free water clearance. The whole concept behind this, I have explained you in a separate video in my YouTube channel. What is free water clearance? If you are very much keen, you can later on after your exam, you can understand. So remember, thiazide diuretics are never given in the treatment of hyperlipidemia. Because thiazide diuretic, their side effect is they increase lipid level in the body. They can also cause hyperglycemia. So that is why they are bad for diabetes mellitus. They are also can cause hyperuricemia. They are bad for gout patient also. So hyperlipidemia, diabetes and gout patient is their side effect of thiazide diuretic. Now spironolactone is contraindicated with enalapril. Why? Because beta spironolactone is a potassium sparing diuretic. It is the only diuretic which will inhibit the excretion of potassium in urine. which will lead to hyperkalemia. Enalapril is an ACE inhibitor, angiotensin convertase enzyme inhibitor, and it also causes hyperkalemia, which I am going to tell you shortly. So when you combine potassium sparing diuretic with ACE inhibitor, there is a dangerous risk of hyperkalemia. So potassium level will increase drastically in the body. So we should avoid combining them together. Okay, we should avoid combining them together because both drugs, they produce additive hyperkalemia. Yes, by blocking aldosterone. So which long-term use of diuretic can cause gynecomastia? The answer for this question is spironolactone, because spironolactone blocks aldosterone receptor on collecting duct of kidney. That is why it is a diuretic drug, but it also blocks testosterone receptor, a similar steroidal hormone. Because it also blocks testosterone receptor, it produces a side effect of gynecomastia, spironolactone. Okay, it is a very non-specific drug. So a patient on dialysis developed cerebral edema due to low osmolarity of plasma, the drug which is used to correct it. Remember, this condition is known as dialysis disequilibrium. This condition is known as dialysis disequilibrium. So what happens in dialysis disequilibrium? If you are taking the blood of a person out, let's say you have taken the blood of a person out and you are filtering the blood through dialysis. Because of this reason, the osmolarity of the blood falls. There is hypoosmolarity. Now remember, when this hypoosmolar blood again goes to the patient, it will lead to cerebral edema. Because when the blood is hypoosmolar, excess of water which is present in blood will enter into the brain, because the water move towards higher osmolarity, hyperosmolarity. Now that is why the patient suffers from cerebral edema. Now to correct this cerebral edema, we must control the osmolarity of blood. So how we can increase the osmolarity of blood? By giving osmotic diuretics. So if you will give osmotic diuretic, they will restore the osmolarity of blood, and that osmotic diuretic is mannitol. So mannitol will restore the osmolarity of blood. That is why it will prevent cerebral edema. It is even the drug of choice for cerebral edema or increased intracranial pressure. So this question has been asked 2-3 times recently in your exam. Dialysis disequilibrium, give mannitol. So which of the following diuretics are contraindicated in presence of heart failure, cardiac failure? Remember, mannitol, it increases plasma osmolarity. We have discussed it is an osmotic diuretic. Increase in plasma osmolarity will increase blood volume, and increase in blood volume will put more pressure on the heart. This blood will go to the heart more. If the blood is going to the heart more, this is known as increase in preload. So that is why it can increase the risk of CHF or heart failure. So that is why never give mannitol in cases of CHF. Even mannitol is contraindicated in CHF. It is also contraindicated in CKD. Same reason. Because in kidney failure, if you will give mannitol, again the plasma osmolarity will increase drastically, which can precipitate heart failure. Okay. Now remember, furosemide, loop diuretic, thiazides, they can be given in, all other diuretics can be given in heart failure, except mannitol. So what is the drug of choice for neurogenic diabetes insipidus? So this question came 2 days back in your exam as well. So beta, what is diabetes insipidus? Diabetes insipidus means that there is some defect in ADH hormone. And neurogenic means beta, the brain neurons, especially hypothalamic neurons, they are not making or synthesizing this ADH hormone. So brain is not making ADH hormone, so there will be deficiency of ADH hormone in the body. So what will be the feature? The feature will be patient will have polyuria because ADH hormone is an antidiuretic hormone. It reabsorb water. So if it is not working, water will be excreted out in urine, polyuria. And because of excessive water excretion, the patient will have increase in thirst also, polydipsia. So these will be the features of your diabetes insipidus. The treatment of choice is, remember, give desmopressin because desmopressin is a synthetic ADH hormone. So give this synthetic ADH hormone in neurogenic diabetes insipidus. Drug of choice is desmopressin. But remember, desmopressin, it is not effective in another type of diabetes insipidus, that is nephrogenic diabetes insipidus. It is not effective in nephrogenic. Nephrogenic means there is presence of ADH in the body, but the receptors of on kidney are not working. Receptors are defective or they are not responding. In this case, remember there is no role of giving desmopressin because even if you will give desmopressin, the receptors are not responding. So in nephrogenic diabetes insipidus, we give thiazide diuretic. So desmopressin, neurogenic diabetes insipidus, thiazide diuretic, they become antidiuretic in nephrogenic diabetes insipidus. Okay, so this is the main treatment. So what is the drug of choice for bleeding esophageal varices? You know that bleeding esophageal varices occurs in portal hypertension, and the most common cause of portal hypertension is when the liver is not working, there is liver cirrhosis. Agreed? You all agree? And remember, in liver cirrhosis also, sometimes the patient can have acute renal failure also. When liver cirrhosis leads to acute renal failure, we call this syndrome as, due to liver failure, there is renal failure. We call it as hepatorenal syndrome. So in cirrhosis, bleeding esophageal varices and ARF or hepatorenal syndrome can happen. And the drug of choice in both cases is terlipressin. Now the drug of choice has become terlipressin. Fine. Octreotide can be given in esophageal varices, but now the drug of choice is terlipressin. It's a better drug. Okay, it's a better drug. So it is a vasopressin hormone kind of a drug, and a synthetic vasopressin. That is why it is ending with the word pressin. So which drug is not used in the treatment of nocturnal enuresis? Nocturnal means during sleep. Enuresis means urination happens. It is also known as bedwetting, and it occurs very commonly in children who are of very small age. They pass out urine. So if a child is more than 6 years of age, that child requires treatment. First treatment is training, like alarm method and etc. If the training fails, then we start drugs. And there are three drugs which have been approved for bedwetting in children. DOI, the D stand for desmopressin, which is an ADH hormone which will reduce urine volume so that urination will not happen. You can give anticholinergic drug oxybutinin because anticholinergic drug, they relax bladder, inhibit bladder contraction, so the person will not have bladder contraction, no urination. And the third drug which we can give is imipramine. Imipramine is a tricyclic antidepressant. It also have anticholinergic effect just like oxybutinin. It also relaxes bladder. So here we don't give tamsulosin. We have discussed tamsulosin is given in the treatment of BPH, benign prostate hypertrophy. It will open the sphincter and it will promote urination. So that is why you will never give tamsulosin in nocturnal enuresis. It will rather promote urination by opening bladder sphincter. Okay. Okay, let's move ahead. So which of the following drugs increase the level of bradykinin? Remember, the drug which increase the level of bradykinin are ACE inhibitor. because ACE enzyme degrades bradykinin in our body. Okay. So any drug which ends with the word pril is an ACE inhibitor. So go with the answer, that is enalapril. And this bradykinin can lead to allergic reactions like dry cough. That is the most common side effect of ACE inhibitor. It can lead to allergic reaction like facial swelling. The face will become swollen, which is known as angioedema. Angioedema. Okay. So which of the following ACE inhibitor is not a prodrug? I think we have discussed in general pharma. All ACE inhibitors are prodrug except two drug, captopril and lisinopril. So captopril and lisinopril are the two ACE inhibitor which are not prodrug. They are not prodrug. They themselves are active form. Okay. Rest all other ACE inhibitor, they are inactive drug, prodrug. Inside the body, they get converted into active form. Great. So a 50-year-old male with type 2 diabetes mellitus found to have 24-hour urinary albumin of 250. So the patient is having microalbuminuria. So if the patient is having albuminuria, this points out to be some kidney disease, chronic kidney disease. So remember, in kidney disease, to protect kidney, the drug of choice, a nephroprotective drug which can retard the progression of this renal disease, is enalapril, ACE inhibitor. So let's write the nephroprotective drug which are given in specially CKD. The most common cause of CKD is, the first one is hypertension, and the second leading cause of CKD in today's time is diabetes mellitus. So overall drug of choice is ACE inhibitor, which will end with the word pril. If ACE inhibitor is not given, you can give ARB, which will end with the word sartan. So they are the drug of choice, pril and sartan. The second drug which has been approved as a nephroprotective drug in renal failure is finerenone. A new drug recently got approved. Finerenone is a brother of spironolactone. It is also an aldosterone blocker. And any student who can recall from our endocrine lecture that which diabetes drug I have told you was cardioprotective and renoprotective in CKD. The third drug which is found to be renoprotective in nephropathy is SGLT2 inhibitor. And these drugs, they will end with the word flozin. Canagliflozin, dapagliflozin, which were increasing urine flow. Empagliflozin, है ना? We have discussed any drug which ends with the word gliflozin. So these are the three nephroprotective drug approved in the treatment of nephropathy, especially CKD due to diabetes or hypertension. Yes. So which of the following drug is contraindicated in pregnancy? Remember, in contraindicated, ACE inhibitor which end with the word pril or sartan, their brother is ARB, angiotensin receptor blocker, or sartan. These drugs are absolutely contraindicated in pregnancy because they inhibit RAS enzyme, and inhibiting RAS system in fetus will lead to renal agenesis. So they are highly teratogenic drug. They can lead to renal agenesis in fetus. So go with the answer enalapril. Okay. So overall drug of choice in pregnancy now has become labetalol. You can give nifedipine, you can give methyl dopa, you can also give hydralazine. Hydralazine. These are the four drugs you use for hypertension in pregnancy. You can make a mnemonic LHMC, Lady Harding Medical College, a girls' college in Delhi. So L for labetalol, H for hydralazine, M for methyl dopa, and C for calcium channel blocker like nifedipine. Okay. So drugs contraindicated in bilateral afferent renal artery stenosis. Let's say you have conducted a renal Doppler, and after renal Doppler you find the afferent blood supply to the kidney is low. Afferent arteries are constricted. That means there is reduced blood supply to the kidney. If there is already reduced blood supply to the kidney, never give ACE inhibitor or ARB. Which drugs are contraindicated? You should give ACE inhibitor or ARB. Pril and sartan wale drugs are absolutely contraindicated because they can increase the risk of ARF, acute renal failure. They will further reduce GFR, which will decrease urine production. So remember one statement I want to tell you in simple word. Remember, ACE inhibitor are given in CKD, chronic kidney disease, but they are contraindicated in AKD, acute renal failure or acute kidney disease. Okay, so go with the answer. तो क्रॉनिक रीनल फेलियर में देते हैं, एक्यूट रीनल फेलियर में एस इनहिबिटर हम नहीं देते. आई होप दिस स्टेटमेंट यू कैन रिमेंबर. ओके. And renal artery stenosis can lead to acute renal failure. Why? Because the blood supply to the kidney. Yes, you can give in unilateral afferent renal artery stenosis. The reason is the other kidney can compensate for the urine production. But remember, nobody is going to ask you unilateral. Okay, you can give in unilateral because the other kidney is fine. Urine production will not fall drastically. So bilateral word is also important. Okay, I have told you this concept. You can give in unilateral. Bilateral में नहीं देना because here the blood supply, the urine production will fall drastically. Unilateral में नहीं होगा. So all of the following statements are true regarding losartan except losartan is an angiotensin receptor blocker. So remember, they are competitive angiotensin receptor antagonists. It's an absolutely true statement. So remember, losartan has additional effect that losartan can reduce uric acid level and it has antiplatelet effect. It blocks thromboxane A2 receptor. So this is also a true statement. So remember, ACE inhibitor, they cause dry cough because of increase in bradykinin level. But sartans, they don't increase bradykinin level. So if any drug, any ACE inhibitor, pril wala drug is producing dry cough, we change the ACE inhibitor to sartans because sartans, they don't increase bradykinin level. That is why they have negligible effect on cough. So here the answer of this question is telmisartan has no effect on PPAR gamma. Remember, PPAR gamma is mainly seen with telmisartan. It is not seen with losartan. Telmisartan has PPAR gamma agonist action just like pioglitazone, which we discussed in diabetes. Okay, fine. Which of the following calcium channel blocker would be useful in the treatment of supraventricular tachycardia by suppressing AV node? Remember, in the treatment of supraventricular tachycardia like atrial flutter and fibrillation, you have to suppress AV node. Because if you will suppress AV node, we can prevent the occurrence of ventricular fibrillation. So the main treatment of SVT is to block AV node because if these impulses reach to the ventricle, VF happens. VF is dangerous, patient dies suddenly. So we have to block calcium channel on SA node, and the best calcium channel blocker that acts on heart is verapamil. Verapamil is the most cardio-specific calcium channel blocker, which blocks verapamil सबसे ज़्यादा calcium heart पे काम करता है. After that, we have diltiazem. Remember, dipine wale drug. These dipines wale drug, they are also calcium channel blocker. Dipine wale drug, they don't act on heart. Dipines wale drug, they don't act on heart. So which calcium channel blocker act on heart? One is verapamil and the second is diltiazem. These two calcium channel blocker are given in the treatment of SVT. But dipines wale calcium channel blocker, they only act on blood vessels or artery. They are artery dilator. Verapamil and diltiazem act on heart. They block SA node and AV node. So which of the following drug is used in the treatment of cerebral vasospasm? Cerebral vasospasm or cerebral artery constriction happens after subarachnoid hemorrhage. After 3 days of subarachnoid hemorrhage, all the blood vessels in the brain, they undergo into spasm. And when they undergo into spasm, patient dies. So we have to treat cerebral vasospasm by giving a cerebral artery dilator. So we have to dilate cerebral artery. So which calcium channel blocker is cerebroselective, which causes cerebral artery dilation? The only drug which is approved for this condition is nimodipine. So that is why nimodipine is given in subarachnoid hemorrhage to treat this cerebral vasospasm. So subarachnoid hemorrhage drug of choice is nimodipine. Okay, nimodipine. Remember this part. So beta blockers should not be combined with which calcium channel blocker? So remember two calcium channel blocker which act on heart is verapamil and diltiazem, because these two, verapamil and diltiazem, they are calcium channel blocker non-DHP type. We call them as non-DHP type. Non-DHP type, how we can remember? They will act on heart and they inhibit SA node and AV node. Because of this reason, if you will combine them with beta blocker, the patient will have increased risk of bradycardia, because beta blocker also inhibit SA node and AV node on heart. So patient will have complete cardiac arrest and the patient will die. So we never combine diltiazem and verapamil with beta blocker. But remember, any calcium channel blocker which ends with the word dipine is calcium channel blocker DHP type dipine. Remember, they are routinely combined with beta blocker. They can be combined with beta blocker because they don't act on heart, they rather act on blood vessels. Okay. So which of the following is not a potassium channel opener? So remember, potassium channel opener, I'll give you a mnemonic, MDH. MDH होता है, MDH नमक, मसाले आते हैं. M for minoxidil, diazoxide, hydralazine, and a potassium channel opener is nicorandil. So first, the answer out here is phenoldopam. Remember, let me correct the spelling for phenoldopam for you. It is phenoldopam. Dopam. Can you tell me phenoldopam, it will act on which receptor? If you see the name. Can you tell me phenoldopam, if you see the name, can you guess on which receptor it will act? Dopam word is coming. And F means first. It is rather D1. D1 means dopamine. One receptor agonist. It is given in the treatment of ARF, acute renal failure. The reason is dopamine receptor causes vasodilation in kidney, which increase GFR. This was a question of this year INI-CET May exam. Okay. So remember, these drugs are all potassium channel opener. Now where these drugs are used, minoxidil, remember M for minoxidil, M for, it is given in male alopecia. It is also given in the treatment of male alopecia. We can remember like this. Diazoxide, D and I word is coming. You can remember diazoxide decrease insulin secretion. It decrease insulin secretion. So can you tell me in which tumor you can give diazoxide? Diazoxide can be given in insulinoma. While hydralazine, H word is coming. It is given in the treatment of hypertension and heart failure. What about nicorandil? Very easy, potassium channel opener, nicorandil. You can see COR word is coming and DIL word is coming. So it is a coronary dilator. So you can remember nicorandil, coronary dilator. And AN word is coming. AN means it is given in the treatment of angina. So it is given in the treatment of angina. So this is the trick how you can remember all these drugs very simply. Okay. So their names itself will tell you where you will be using it. Fine. So which of the following drug causes SLE? So SLE, remember, is caused by ship drugs. I have told you ship drugs in general pharmacology. Can you recall what does SHIP stand for? Sulfonamide, H for hydralazine, I for isoniazid, P for prokinamide, and D for dapsone. So hydralazine is a part of ship drug, and ship drugs, they produce drug induced SLE. Drug induced SLE is known as DLE. Great. So next question is treatment of choice for cyanide poisoning. Remember, cyanide poisoning can be caused by, it can be caused by side effect of nitroprusside. Nitroprusside is an antihypertensive drug. It goes to the liver and it gets converted into cyanide. Okay. Now remember, when a patient of cyanide poisoning comes, the first treatment is hydroxycobalamin. It is the overall drug of choice, which is vitamin B12. Then we give nitrites like sodium nitrite or amyl nitrite. Agreed. Later on, we will give thiosulfate, especially sodium thiosulfate. Together, it is known as cyanide kit. So these three classes of drugs we give for the treatment of cyanide poisoning. Okay. The first drug should be vitamin B12. It will chelate the cobalt which is present in cobalamin will directly inactivate cyanide. So mechanism of action of sodium nitrite, which we have just discussed in cyanide poisoning. So remember, sodium nitrite, nitrite word is coming. Nitrite means it is a direct nitric oxide donor. It donates which molecule beta? Nitric oxide. Nitrite word is coming. This nitric oxide converts hemoglobin into methemoglobin. And this methemoglobin directly binds and inactivates, it will bind to cyanide. So it will inactivate cyanide directly. So this is how sodium nitrite will act. So what is the answer? The answer of this question comes out to be beta A. I hope you have understood the mechanism. Simple and easy. So antihypertensive of choice in a patient of diabetes with renal damage. So can you tell me the answer? We have already discussed in great detail. That is ACE inhibitors. ACE inhibitors. Okay. Methyl dopa, it is given for hypertension in pregnancy, but now the drug of choice has become labetalol. Beta blocker is given for the treatment of hypertension with heart disease, because beta blocker will also suppress heart and it will protect heart. Let's write certain heart disease like angina, MI, arrhythmia, HOCM, hypertrophic obstructive cardiomyopathy, aortic dissection. So any hypertension with heart disease word comes, then your drug of choice will become beta blocker. Thiazides are given in hypertension if the patient is having osteoporosis. Then we prefer to give thiazide because thiazides, they preserve calcium. ACE inhibitors are the drug of choice for hypertension with diabetes mellitus, CKD. It is also the drug of choice for retinal, कोई retina में problem है, ठीक है, diabetic retinopathy. It is also the drug of choice for hypertension with stroke. It is also the drug of choice for hypertension due to scleroderma or excessive collagen deposition, which can make the artery stiff and lead to hypertension. So in all these conditions, you prefer to give ACE inhibitor. Yes. So antihypertensive of choice in angina patient. Beta, now can you tell me angina is a heart disease? And which of the following drug will also act on heart and reduce heart rate and decrease oxygen demand in angina patient? So the answer should be your beta blockers. I hope you have understood the whole concept. Yes, in hyperthyroidism also, we give beta blocker. Thyroid storm we discussed in endocrine. To protect the heart from arrhythmia, we give. So antihypertensive of choice in hyperthyroidism should be. Antihypertensive of choice in hyperthyroidism is beta blocker. This question came beta last year in NEET exam. Like propranolol we discussed, है ना, thyroid storm, peripheral. But remember, beta blockers are contraindicated in asthma. We discussed it. In autonomic nervous system, they are contraindicated in asthma. So here the patient is having asthma. So if the patient is having asthma, Then we will not give beta blocker, we will give a similar calcium channel blocker which will act on heart and protect from arrhythmia. So either you can give verapamil which was acting on heart, or you can give diltiazem instead of beta blocker. So we can use them as a replacement for beta blocker in asthmatic individual. So here the answer comes out to be your diltiazem. This was the last year NEET question. Fine. So which of the following is useful in intravenous therapy for hypertensive emergencies except? So the answer of this question is, remember, is thiazide diuretic. Remember, thiazide diuretics, they are the drug of choice for essential hypertension, which is the most common type of hypertension, but they are not effective in hypertensive emergency. Hypertensive emergency means when the blood pressure is more than 180 by 120, because thiazides are not very effective drug. They are not very effective drug. Okay. Beta, in hyperthyroidism, the main feature is the patient is having cardiac arrhythmias and the patient is also having peripheral high blood pressure. So you have to give one drug which can control arrhythmia as well as control the blood pressure. Nifedipine has a problem. Nifedipine only acts on blood vessel. It will reduce peripheral blood pressure, but nifedipine itself causes reflex tachycardia. Because nifedipine causes reflex tachycardia, it itself will lead to cardiac arrhythmias. It will increase cardiac arrhythmia. That is why we don't give nifedipine in hyperthyroidism. I hope you have understood. One student was asking, Gayatri ji, I hope you have understood. Reflex tachycardia will further aggravate arrhythmia. So here the answer is thiazide diuretics are not given in hypertensive emergency. We give nitroprusside, nicardipine. Nicardipine is now considered to be the drug of choice. We can give enalaprilat. Remember, it's an ACE inhibitor, which is the active form of enalapril. It can be given intravenously for hypertensive emergencies. Okay? So the mechanism of action of sodium nitroprusside and nitrate is, it's very simple and easy. Both these drugs, they will donate nitric oxide because nitro word is coming in both of them. So they are nitric oxide donor, and nitric oxide enters into the blood vessel, and inside the blood vessel nitric oxide stimulate one enzyme known as soluble guanylyl cyclase enzyme. When soluble guanylyl cyclase enzyme is activated, it will increase the level of cyclic GMP, and cyclic GMP causes vasodilation. So this is the mechanism you have to remember. So what is the answer of this question? Yes, the answer of this question comes out to be B, stimulation of guanylyl cyclase enzyme. Now, next question is very important that both these drugs are increasing the production of cyclic GMP. Cyclic GMP after some times becomes degraded by phosphodiesterase enzyme. Which enzyme degrades cyclic GMP? Phosphodiesterase. So there is a question that we have drugs sildenafil and tadalafil, which are the drug of choice for impotence or erectile dysfunction. These drugs are phosphodiesterase 5 inhibitor. They will also increase cyclic GMP level by inhibiting degradation of cyclic GMP, and these drugs should never be combined. These drugs should never be combined with nitrates because nitrates also increase cyclic GMP level. And both these drugs are increasing cyclic GMP level. One is increasing the production by nitric oxide. Sildenafil and tadalafil are inhibiting the degradation of cyclic GMP. It will lead to massive vasodilation. Because of massive vasodilation, what will happen to blood pressure? The patient will go into hypotension and there will be sudden death. So we never combine sildenafil and tadalafil, which are phosphodiesterase inhibitor, with nitrates. Okay, sudden death. Many cases of sudden death have been reported. Okay. So never combine sildenafil and tadalafil with nitrate. Very frequently asked question. So nitrates are given in all of the following condition except. Now remember, what are nitrates? Nitrates, they are venodilators. They dilate veins. And by dilating vein, remember, they reduce preload to the heart. They reduce preload to the heart. Can we say because of this reason, there will be decrease in oxygen demand of the heart, because heart has to work now less amount of blood the heart has to pump forward. So that is why nitrates are given in angina and MI. They are the mainstay of treatment. Remember, we want to reduce preload in cases of left ventricular failure. We reduce preload in left ventricular failure because in left ventricular failure, patient suffers from pulmonary edema. So to reduce pulmonary edema or blood collection in lungs, we have to reduce the blood supply to the right part of the heart. We have to reduce preload of the heart. Remember, nitrates are given in LVF, but nitrates are absolutely contraindicated in right ventricular failure because the treatment of right ventricular failure is to increase preload by giving fluids. By giving fluids. Remember, in RVF treatment, we increase preload, while in left ventricular failure, we reduce preload by giving nitrates. Okay? Yes. Very good. Nitrates. So yes, Sid, you are absolutely right. We have discussed a mnemonic of pulmonary edema, how to treat LMNOP. Very good. Shabash. Nitrates are given in all of the following condition except, I think this is a repeat question. Let's ignore it. Main action of nitrate in angina. So tell me the answer, beta. Now you know the answer. It's a very repetitive question. Yes, they are venodilators, so they will reduce preload to the heart. Deepak, what is your question? You have just written why, sir. Why means which question? Why today is Monday? It can be a question. Why, sir, you have not applied cold cream on your face? So, what is the question, Deepak Raji? So, you type your question. Meanwhile, I'll read your question and we will continue because your time is precious. The nitrate which is used, which does not undergo first pass metabolism in liver. So when we give nitrates, all are degraded first in liver except ISMN. Isosorbide mononitrate, when given orally, it will not be degraded in liver. Can you tell me what should be the bioavailability of oral bioavailability of isosorbide mononitrate? The answer is because it is not degraded in liver, it has overall 100% oral bioavailability. Okay. So which of the following agent is a funny channel blocker on SA node? The drug which block funny channel on SA node is ivabradine. So ivabradine inhibit funny channel on SA node. That is why it will decrease heart rate, which will decrease oxygen demand of the body. Because it decreases oxygen demand of the body, it is given in the treatment of angina. It is also approved in the treatment of CHF also, chronic heart failure. Fine. Let's talk about other. Then we have nicorandil. I think nicorandil we have discussed, coronary dilator. It is a potassium channel opener which dilates coronary artery, given in the treatment of angina. We have just discussed it. Ranolazine, remember, Na word is coming. It is some sodium channel blocker, which is also given in the treatment of angina. All are given in angina. Trimetazidine. Remember, tri means triglycerides, like fatty acids. Fatty acids are triglyceride. Meta means metabolism inhibitor. It inhibits the degradation of fatty acids or it inhibits oxidation of fatty acids by inhibiting one enzyme, some PFOX enzyme, partial fatty acid oxidation inhibitor. Because of this reason, the heart will not able to utilize fatty acid for its energy production. Heart will shift its metabolism from fats to glucose. So it will shift the metabolism to glucose, and glucose requires less oxygen to obtain energy. Okay, very good. So which of the following drugs? So here the answer was ivabradine. Which of the following drug can worsen angina? Anyone? The drug which can worsen angina is dipyridamole because it can lead to coronary steal syndrome. Coronary steal syndrome means it will shift the blood from ischemic area of the heart to non-ischemic area. Okay, so that is why it is no longer used in angina. Remember now that one more drug which can also cause coronary steal syndrome is isoflurane. So isoflurane is a general anesthetic drug. It can also cause coronary steal syndrome. Second drug you have to remember is dipyridamole. Okay. Yes, we have discussed four drugs which can cause. Because sometimes it is confusing, so you have to revise again and again. If you'll revise 2-3 times, now your concepts will become very strong. One revision is not enough in medical science. First time when you will read, you will just understand the names of drugs. Second time when you will read, then you will understand the concept. And third time you will become a pro. A patient presented to hospital with chest pain and palpitation. Okay. ECG of patient confirmed to be non-ST elevated MI. NSTEMI. Non-ST elevated MI. Which of the following drug is not useful? Remember, we never give streptokinase. Streptokinase, remember, it is contraindicated in non-ST elevated MI because the thrombus is not very large, the infarct is not very large. Streptokinase, it is only given in the most dangerous type of MI, that is STEMI. So it is only given in ST elevated MI. Okay, fine, good. So remember STEMI. What is streptokinase? We will discuss. So this is a very frequently asked question, that which drug has no mortality benefit in heart failure patient. Remember, in chronic heart failure, we have certain cardioprotective drug. The drug which protect heart, they have mortality benefits. Mortality benefit means, beta, they can prolong the life of a person. They can increase the lifespan of a person. So remember, ACE inhibitors, spironolactone, beta blocker, they all have mortality benefit. I have given you a mnemonic also. The drug which has no mortality benefit is digoxin. Remember, digoxin is an inotropic drug. Inotropic drug means it tells a dying heart to work more. It is telling or stimulating heart to work more. Do you think it is good for a dying heart to work more? The answer is no. Remember, digoxin rather increase cardiac mortality. It can suddenly increase the risk of cardiac death. So remember the answer, digoxin has no mortality benefits. So all are true about starting beta blocker therapy in a patient of CHF. So remember, beta blocker in CHF, only 4 beta blockers are approved. How many beta blockers are approved? Only 4. This is a very frequently asked question. Okay. Okay. So you can remember a mnemonic, beta blocker may beta blocker may sorry, write a mnemonic, new beta blocker may protect heart in CHF. So new beta blocker may be given in CHF. N for nebivolol, it can be given, which has a cardioprotective effect. Bisoprolol, metoprolol, and one salt of metoprolol is given only, succinate salt, and carvedilol. Only 4 beta blocker are approved to show cardioprotective effect in CHF. So remember, beta blocker, when we start in CHF, we start in 1/8 of the dose because very high dose will suppress the heart, decrease the cardiac output. So we start with low dose. So this is a true statement, and we gradually increase the dose of beta blocker in heart failure. Now remember, beta blocker are given in CHF, chronic heart failure, when the heart is dying slowly. But beta blocker are absolutely contraindicated in acute heart failure. In acute heart failure, the cardiac output is already very low. Here we give beta agonist like dobutamine, norepinephrine. So they are contraindicated in AHF. So we with beta blocker we monitor periodically heart function. Yes, carvedilol are preferred drug. True. So remember, the answer is C. Beta blocker are given in CHF, but they are contraindicated in acute heart failure. Okay? All of the following are incorrect about except. So you have to find the true statement. So there is a new drug for CHF, that is sacubitril. Yes, sacubitril is a drug which inhibits neprilysin enzyme. By inhibiting neprilysin enzyme, it increases the levels of natriuretic peptides inside the body. And natriuretic peptides, they reduce preload and they are protective for heart. So omapetrilat is another drug right now not approved but has been asked, is a dual neprilysin plus ACE inhibitor. True statement. So it's a INI-CT question and NEET question. Nesiritide is a BNP analog. Yes, nesiritide is brain natriuretic peptide analog. And nesiritide can be given orally. Now this is a false statement. Remember, any drug which ends with the word tide, any drug that ends with the word tide is a peptide. Any drug. Teriparatide, octreotide, nesiritide. Peptides are only given by injection. Peptides are not absorbed orally. They cannot be given orally. The reason is pepsin trypsin enzyme in GIT will degrade peptide. So all are true about digoxin except, remember, digoxin first statement is digoxin stimulate SA node and AV node. Now this is a false statement. Digoxin inhibit SA node and AV node on heart. Why? Because digoxin has vagomimetic effect. It has vagomimetic effect. That is why digoxin, apart from use in chronic heart failure, digoxin is also given in the treatment of supraventricular tachycardia. So another use of digoxin is supraventricular tachycardia. Yes, digoxin inhibit sodium potassium ATPase in myocardial fiber, which produce inotropic effect. And inotropic effect, it will increase cardiac output. It is given in the treatment of CHF, chronic heart failure. So first use of digoxin is SVT because it inhibits SA node and AV node just like vagus nerve. Second use is CHF. So it is given in the treatment of CHF and atrial fibrillation. True statement. True statement. Digoxin we have discussed on first day, it is excreted unchanged in urine by P glycoprotein. Yes, we have discussed. It is excreted into the kidney. Okay. So the false statement out here is A. It does not stimulate SA node and AV node. Digoxin blocks it. So tell me the answer of this question. I think we have discussed in general pharma. This question was asked in NEET and INI-CT mainly. This is the question of INI-CT 2023. A patient on digoxin, potassium chloride, clarithromycin, atenolol, triamterene developed atrial fibrillation with controlled ventricular rate. So atrial fibrillation means arrhythmias are happening. Digoxin itself can cause atrial fibrillation. And serum digoxin level is raised. Remember, the normal level of digoxin in serum is 0.6 to 2.0 milliequivalent per 2.0 nanogram per ml. This is the normal level. So you can see the blood level of digoxin is 3.5. So the answer of this question is clarithromycin, because we have discussed clarithromycin inhibit which protein? P glycoprotein. And digoxin is excreted into the urine by P glycoprotein. So it will increase digoxin blood level. Okay. Increase in digoxin blood level will lead to arrhythmias on heart. No, not CYP beta, P glycoprotein. Here in this case, it's a P glycoprotein inhibitor. So which of the following drug causes gynecomastia except? So remember the mnemonic gynecomastia, disco, a very famous mnemonic we have discussed many times. Digoxin, TB drug isoniazid, diuretic spironolactone because blocking testosterone receptor, one antihistaminic drug given for peptic ulcer, cimetidine, ketoconazole, antifungal drug, and omeprazole, a proton pump inhibitor. They all can cause gynecomastia. So here the answer should be your amiloride. Okay, amiloride. So the most effective treatment for digoxin toxicity is, remember digoxin is also known as digitalis because it is obtained from digitalis plant. So another name of digoxin is digitalis. The overall antidote of digoxin toxicity is digibind. Digibind, it is also known as digifab. Why? Because it is a fab fragment antibody, because fab part of the antibody binds to a drug like digoxin against digoxin. Okay. Now remember, in digoxin poisoning, hemodialysis has no role. There is no role of hemodialysis in digoxin poisoning because digoxin has a very high volume of distribution. That means it is not present in blood, it is rather deposited in tissues. So why you are taking out the blood of a patient and doing hemodialysis? There is no point of doing that, है ना? Cardioversion we don't do. Lignocaine, it is given for the treatment of digoxin induced VF. If the patient is having ventricular fibrillation due to digoxin, only then we give lignocaine to treat the arrhythmia due to digoxin. Otherwise, we don't give lignocaine in digoxin poisoning. So digoxin is used in CHF. Is used in, another use of digoxin, the question is not framed properly. So digoxin, remember, it can be given in atrial fibrillation. Digoxin is absolutely contraindicated in HOCM. In HOCM, the drug of choice is beta blocker. Fine. Digoxin is absolutely contraindicated in hypokalemia because hypokalemia can increase toxicity of digoxin. And two drugs which themselves can cause hypokalemia is loop and thiazide diuretics. So loop and thiazide, by producing hypokalemia, can lead to digoxin toxicity, and digoxin is absolutely contraindicated in WPW syndrome, which is Wolff-Parkinson-White syndrome. Okay. So which antiarrhythmic drug does not belong to class B, class 2? So remember, antiarrhythmic drug classification you have to remember. So we have class 1, 2, 3, 4, 5. 5 classes of antiarrhythmic drug. Mnemonic is Sobi-Poca. So first is sodium channel blocker. Second we have is beta blocker. Third we have is potassium channel blocker. Then we have is calcium channel blocker. And all miscellaneous drugs like adenosine, magnesium sulfate, they come under which class? Adenosine, magnesium sulfate, they come under class 5. Now remember, all beta blockers are under class 2. So class 2 contains beta blocker, except one beta blocker, except sotalol. This is a very frequently asked question. Sotalol is under class 3 because sotalol has a special property that sotalol, although it is a beta blocker, it has special potassium channel blocking action. That is why we don't keep sotalol under class 2, we rather keep under class 3. Okay, so which beta blocker is not under class 2? So antiarrhythmic drug which can cause, themselves can cause a side effect of torsades de pointes. Now remember, torsades de pointes is an arrhythmia which can occur because of QT prolongation. Agreed? And QT prolongation is seen with those class of a drug which causes potassium channel blocking. The drug which block potassium channel on heart, they can cause QT prolongation, and they can cause one arrhythmia, torsades de pointes. Remember which class of antiarrhythmic drug block potassium channel? 1A and class 3. 1A and class 3, they can block potassium channel. So quinidine is 1A, diisopyramide is 1A, prokinamide is 1A. So Cupid is 1A, lidocaine is 1B, propanolol is beta blocker under class 2. So what is the answer of our question? The answer of our question is A, B and C. Cupid, remember a mnemonic Cupid. So in 1A we have drug Cupid. Q for quinidine, D, P for prokinamide, D for diisopyramide. In class 3, just remember two drugs, amiodarone and sotalol. So which beta blocker can cause torsades de pointes? That is amiodarone. Sotalol can cause QT prolongation. Fine. Now, in a patient of prolonged QT syndrome and intermittent torsades de pointes, which of the following drugs should be given? So remember, the drug of choice for torsades de pointes or long QT syndrome is magnesium sulfate. Magnesium sulfate is the drug of choice for TDP. Okay, torsades de pointes. Now, drug of choice for ventricular arrhythmia due to MI is always and always amiodarone. Amiodarone now has become the drug of choice for VF or VTs. Okay. Earlier it was lignocaine. You can also give lignocaine also, but now the drug of choice has become amiodarone because it is the most effective drug. Remember, another name of lignocaine is xylocaine. It can also be given. Other drugs can also be given. But remember, the most effective antiarrhythmic drug which can save the life of a person is always amiodarone. So what is the not adverse effect of amiodarone? Amiodarone adverse effect, you can write a mnemonic. Just write, but don't speak it. Which? Okay. So amiodarone, it can cause blue or purple man syndrome because the color of skin becomes purple. It can lead to interstitial pulmonary fibrosis. Amiodarone, remember IOD word is coming. It is having iodine in it, and because of iodine, it can cause thyroid abnormalities. Both hypo and hyperthyroidism can happen. Amiodarone deposits in cornea, just like a flower. Just like a flower, it will deposit in cornea. It can cause cornea verticillata, which is also known as vortex keratopathy. And it is a hepatotoxic drug also. It is also a hepatotoxic drug. Remember, amiodarone, it is rather given in the treatment of tachycardias. It is not given in the treatment of bradycardia. And ventricular tachycardia, we give it. Okay. Okay. So remember a mnemonic, bitch. A better mnemonic. A patient presented with palpitation and ECG shows PSVT. Remember, in PSVT ECG, there will be increased heart rate, but in PSVT, remember, there will be absent P waves. You will not find P waves. QRS complex and T wave will be in normal shape, regular morphology. P waves are absent. So remember, in PSVT, the first treatment is we do vagal stimulation. We do give vagal stimulation by giving carotid massage because we have to suppress AV node. Carotid massage, we can do Valsalva. If it doesn't suffice, and in most of the cases it is useless procedure, but for our theory, yes, vagal stimulation, we start a drug A, B, C. So the first drug to be started in PSVT is always adenosine, IV. Dose is 6, 12 and 12 milligram. Total 30 milligram of 3 injections you can give. Okay. So it is given for acute treatment of PSVT. During an acute attack of PSVT, we give adenosine. Then we give beta blockers. Beta blockers are given for maintenance. It is given for maintenance. You can also give calcium channel blocker like verapamil. Verapamil is given for the treatment of PSVT in asthma. In asthma, we give verapamil because both adenosine and beta blocker, Their side effect is asthma. They are contraindicated in asthma. The first two drugs are contraindicated in asthma. So we don't, in asthma, only drug to be given is calcium channel blocker. Yes, if the patient is hemodynamically unstable, you will do synchronized cardioversion. Okay, always for any arrhythmia, any atrial arrhythmia, unstable patient, don't give drug. First do synchronized cardioversion. In any ventricular arrhythmia, if the patient is hemodynamically unstable, first give DC shock. Atrial arrhythmia, synchronized cardioversion. Ventricular arrhythmia, DC shock. ठीक है? If the patient is unstable, BP is low, then we start the drugs. So, mechanism of action of atorvastatin. Remember, atorvastatins, they are lipid lowering drug and they inhibit which enzyme? They are competitive inhibitor of HMG CoA reductase enzyme. ठीक है? Atorvastatin, rosuvastatin. Which drug reduce bile acid absorption? The drug which reduce bile acid absorption and reduce cholesterol levels in the bodies are raisins. Like, and raisins, they will start with the word cholestyramine, cholestypol, etc. The drug which is PPAR alpha agonist are fibrates. They reduce triglyceride level like fenofibrate. The drug which reduce intestinal cholesterol absorption is ezetimibe. Ezetimibe. Okay. So which hypolipidemic drug can reduce lipoprotein A level? So the only hypolipidemic drug which can reduce lipoprotein A level is niacin, vitamin B3. So niacin is also used as a hypolipidemic drug, but the main side effect of niacin is it increases uric acid level. That means it can precipitate an attack of gout. This is a question which has been asked. Okay. Lipoprotein A is a defective form of LDL, which is a marker of atherosclerosis. So we have to reduce lipoprotein A levels. So in a patient of hypertriglyceridemia, taking rosuvastatin, which of the following drug will be best to reduce? So remember the normal triglyceride levels in blood, they should be less than 150. So let's say if the patient is having high triglycerides, more than 150, the first drug you will start is statins. Always you will start statin. But if the triglycerides are more than 350, in this statins, you will add a drug fibrates. You will add a drug fibrates because fibrates, they can reduce triglyceride by very good level. So this is how we manage hypertriglyceridemia. So can you tell me the answer? The patient is already taking rosuvastatin. This question came last year. You will start which drug? Any drug which is ending with the word fibrate? Fenofibrate. I hope it's perfectly fine for you. Now, this is a very commonly asked question. Remember, it's a very important question, many times asked. Which of the following drug is a PCSK9 inhibitor? Remember, if we inhibit PCSK9 in liver, inhibition of PCSK9 in liver will increase LDL receptors on liver. LDL receptors on liver will increase, so it will reduce blood LDL level. Liver will take now LDL from blood. And I hope now can you see now the video again? I think we have restored our connection. There was some glitch. I don't know what happened. Probably some backup issue. I hope it's fine. You're able to. Yes, let's continue. So, which drug is a PCSK9 inhibitor, 2 monoclonal antibody, alirocumab and evolocumab? These are very commonly asked questions. These drugs they decrease LDL level from the blood. They decrease LDL level from the blood by inhibiting PCSK enzyme in liver. And these drugs are even more effective than statins. Okay, fine. How to remember? Remember LOC word will come in both of these drugs. LOC word is coming, LOC word is coming. Ezetimibe we have discussed, it inhibit one transporter, NPC1L1 transporter, and it decrease intestinal absorption of cholesterol. So it also decreases LDL level in the blood because LDL contains cholesterol. N-acetrapib, it inhibits CETP enzyme. Some full form you don't have to remember. CETP word is coming. Cholesterol ester transfer protein. This drug has been meant to increase a good lipid in our body, HDL. Icosapentaenoic acid is a type of omega-3 fatty acids which is present in fish, which also reduce cholesterol level. Just write one more drug because this drug was asked 3 months before in your INI-CT exam. The drug name is bempedoic acid. Another drug, new drug is bempedoic acid. Now, bempedoic acid is a competitive inhibitor of competitive inhibitor of an enzyme known as ATP citrate lyase enzyme. It also decreases LDL level, LDL production in liver, and it is combined with statins to decrease LDL level in the blood. So bempedoic acid, remember this question came in INI-CET 3 months back. ठीक है? Question was whether it is a competitive inhibitor or non-competitive inhibitor. So the answer was it's a competitive inhibitor. Okay? Competitive inhibitor. So we are done with cardiovascular. Let's talk about few drugs. So which of the following antiplatelet drugs are pro-drug? So let's talk about antiplatelet drugs. Now remember any antiplatelet drug which will end with the word grel will be a pro-drug, and which will end with the word grelor will be an active drug. This is a trick, remember. And these drugs are known as ADP receptor or P2Y12 blocker. This is some receptor present on platelet. If you block this ADP or P2Y12 receptor, it will inhibit platelet aggregation. So can you tell me which drugs end with the word grel? So clopidogrel and prasugrel are two antiplatelet drugs which block ADP receptor. They are pro-drugs. Remember this trick always. Okay, fine. Grelor wale drugs are not pro-drug. So clopidogrel is converted into active form. I hope we remember clopidogrel. We have discussed earlier also. So remember Cl. So it is converted by CYP to C19 enzyme into active form. And the drug which inhibits CYP enzyme is omeprazole. So avoid combining clopidogrel with omeprazole. So the answer out here is CYP2C19. So which of the following drug is used against GP2B3A? Remember GP2B3A is a receptor on platelet which causes platelet aggregation. So three drugs which are GP2B3 that is glycoprotein 2B3A inhibitor are EAT drug, eptifibatide, A for epsiximab. These are antiplatelet drug. Names are very important, and tirofiban. So they block GP2B3A receptor. So your answer will be this one. Vorapexar, a new drug. It is a PAR. PAR word is coming. Antagonist. It is a new antiplatelet drug. Some protease activating receptor or PAR receptor. Cilostazol is a phosphodiesterase. So I think you can see me again, hear me again. Is it fine now? Is it fine now again? I'm visible and audible to every one of you. There's some, I don't know why there's some glitch today in my studio. Okay, so it's fine. Yes, let's continue. So remember the answer is your apixaban. So aspirin is a COX inhibitor, which we are going to discuss in next chapter. It is a COX inhibitor, which decrease thromboxane A2 production. All these drugs are antiplatelet drug. So what is the drug of choice for thrombocytopenia? I think we have discussed. We will not go into the detail in anti-cancer chapter. So anti-cancer drugs, they can lead to bone marrow suppression. And the drug which we give is oprelvicin, which is interleukin 11. And I have given you a trick how to remember. Kin means interleukin 11. L-trombopag, remember it is a thrombopoietin agonist. It is a thrombopoietin agonist which will increase platelet count. Romiplostim, name itself is telling you it is a platelet stimulator. Platelet stimulator, name itself is telling you it will also increase platelet count. Fostamatinib is a tyrosine kinase inhibitor. These three drugs are given in the treatment of a disease known as ITP. They have been asked. ITP stands for idiopathic thrombocytopenic purpura. Idiopathic thrombocytopenic purpura. Last to last year, NEET exam, fostamatinib was asked. So match the following anticoagulant drug. So apixaban inhibit which coagulant factor or anti-clotting factor? You can see XA means, XAban means it will inhibit which factor? It will inhibit XAban. So the answer is A, apixaban. Dabigatran, remember D for direct, TR means thrombin, A means antagonist. D for direct, D for direct, TR for thrombin, AN means antagonist, is a direct thrombin inhibitor. Dicumarol, remember coumarins are a chemical, coumarins are a group of chemical like dicumarol and warfarin. They inhibit vitamin K. So dicumarol is a vitamin K inhibitor. 3. Heparin activate antithrombin 3, which we have discussed many times. And antithrombin 3 inhibits your clotting factor 2 and 10. Fine, that's great. So a patient was started on anticoagulant drug. He developed lower limb and toe necrosis in 2 days. The implicated drug is. So remember, there are certain anticoagulant drug. I'll give you a trick which sometimes have a side effect of increase in coagulation. Certain anticoagulant drug, they increase coagulation, which can lead to limb necrosis. Now understand this trick. If this coagulation is occurring in less than 5 days, if it is occurring in less than 5 days, go with warfarin. So warfarin increases coagulation in initial 5 days, and if it is occurring after 5 days, go with heparin. Go with heparin. Let's see the reason for it. In initial 5 days, why warfarin increases coagulation? Because it causes protein C and S deficiency. Protein C and S deficiency, protein C and S are anti-clotting factor. And if their deficiency happens with warfarin, it will increase coagulation. And the main reason why warfarin causes coagulation after 5 days, because it can lead to a dangerous hypersensitivity known as HIT, heparin induced thrombocytopenia. Now see the question. The answer is 2 days. Answer is 2 days. So you will go with heparin or warfarin? Yes, you will go with warfarin. Why? Okay, done. Now remember, warfarin in our body inhibits vitamin K enzyme in liver. The enzyme name is weak or C1 enzyme, vitamin K epoxide reductase enzyme C1. And warfarin is degraded or metabolized in our body by which CYP enzyme? CYP2C9 enzyme. Agreed? Now, some people have deficiency or excess of this enzyme. So, Indians, we are deficient in, we have less amount of this weak orange CYP2C9 enzyme. Americans have more amount of this enzyme. So that is why before giving warfarin, do genetic testing for this enzyme. This is known as pharmacogenetic testing. So warfarin require VCOR-C1 and CYP2C19 testing. Let's write all the genetic tests before giving any drug. Let's see which genes are present. Thiopurine methyl transferase. Let's call this enzyme as TPMT enzyme. TPMT enzyme degrades a thiopurine known as azathioprine. So before giving azathioprine, do the testing of thiopurine methyl transferase enzyme. Name is same. This was a recent question. Thioprine word is coming. Thiopurine word is coming. Fine. Now pseudocholinesterase enzyme. Pseudocholinesterase enzyme, choline word will come in this drug, succinylcholine. Succinylcholine is degraded by which choline enzyme? Pseudocholinesterase. Some people are deficient or they have mutant variety of this enzyme. So do pharmacogenetic testing before giving succinylcholine. This test is known as Dubuque number. When we check the activity of pseudocholinesterase enzyme before giving succinylcholine, we call it as Dubuque number. Pyrimidine dehydrogenase enzyme will degrade a pyrimidine. You know a pyrimidine? 5-fluorouracil. It's a pyrimidine. It is degraded by this enzyme. So before giving, do this testing. This is a very important question for NEET and INI CET. In FMG, it is not asked. Okay. Fine. What is the false about high molecular weight heparin? So remember, high molecular weight heparin as compared to low molecular weight and ultra low molecular weight heparin. Let's compare them. So high molecular weight heparin inhibit 10 and 2. It is true. It inhibits 10 and 2 clotting factor. Low molecular weight, it inhibits 10 and 2. And ultra low molecular weight heparin only inhibits clotting factor 10. So high molecular weight heparin, it causes an allergic disease, hypersensitivity disease, that is HIT, heparin-induced thrombocytopenia. Low molecular weight can also cause heparin-induced thrombocytopenia. Ultra low molecular weight heparin, they don't produce heparin-induced thrombocytopenia. Now high molecular weight heparin, it is renal safe because it is such a big molecule that it is not excreted out in urine, but they both are contraindicated in renal failure. High molecular weight heparin is given IV. Other two, ultra low molecular weight heparins and low molecular weight heparin, are given by which injection? They are given by subcutaneous injection. Now how to remember the name? High molecular weight heparin, it is known as just heparin. Low molecular weight heparin, they will end with the word parin, like enoxaparin, dalteparin. Ultra low molecular weight heparin, they will end with the word perinox, fondaparinux, idraparinux. So let me write their name. High molecular weight heparin, it is simply known as heparin. Low molecular weight heparin, they will end with the word parin, like enoxaparin, dalteparin. So now you know the property. Ultra low molecular weight heparin, they will end with the word perinox. Perinox means fondaparinux, idraparinux. Okay, they will end with the word perinox. So this is how you can remember them. So what is the incorrect? This question came last year. Match regarding the antidote of anticoagulant. Apixaban, rivaroxaban, their antidote is andexanet alpha. Dexa means it is a clotting factor 10 which is given from outside. The antidote is andexanet alpha to stop bleeding. Dabigatran, daba ke daru piyo. Dabi means daba ke daru piyo. That is idarukizumab, an antibody against dabigatran. For warfarin, yes, we gave vitamin K, true. antidote because warfarin inhibit vitamin K dependent enzyme. And enoxaparin, again, the true statement is protamine sulfate. All are true. So the question would have been framed like this. Let's frame the question properly. Fondaparinux, ultra low molecular weight heparin. Remember, it has no antidote. Protamine sulfate is an antidote only for high and low molecular weight heparin. So the question was having, instead of fondaparinux, enoxaparinux, just write fondaparinux. So no antidote. So does protamine sulfate acts against fondaparinux, ultra low molecular weight heparin? The answer is no. Protamine sulfate is not effective against ultra low molecular weight heparin. So which of the following drug does not require monitoring? So remember, warfarin requires monitoring. Yes, we do PT with INR monitoring, prothrombin time with INR. Lepuridin, it requires monitoring, APTT monitoring. Heparin also requires APTT monitoring. Remember, high molecular weight heparin requires monitoring, while enoxaparin, which is a low molecular weight heparin, it is a much safe drug. No monitoring is required. Okay, no monitoring is required. Fine. So next question is, a pregnant woman was suffering from deep venous thrombosis. She was taking enoxaparin. After how many weeks of pregnancy warfarin can be started? Remember, warfarin, it is contraindicated in first trimester of pregnancy. That means up to how many weeks? Up to 12 weeks. So when you can restart warfarin in a female? After how many weeks of pregnancy you can start warfarin? So you can start warfarin after 12 weeks of pregnancy. In first trimester, it is teratogenic. It can cause bone and cartilage defect. It can cause saddle nose, etc. Now, streptokinase is not used in. Remember, streptokinase, it is a thrombolytic drug. Thrombolytic drugs, they are also known as fibrinolytic drugs. That means they will remove the fibrin which is already deposited in a blood vessel. And these drugs, they will end with the word kinase or they will end with the word tiplase. Either they will end with the word kinase or tiplase, like streptokinase, urokinase, L-tiplase, retiplase, and tenictiplase. Okay? These are the drugs. Now remember, thrombolytic drugs, they have only 3 uses, the most dangerous uses. So remember, they are given in STEMI, but they are absolutely contraindicated in NSTEMI. Okay, they are only given in ST elevated MI, they are not given in non-ST elevated MI. They are given in ischemic stroke, but remember they are contraindicated in hemorrhagic stroke because they themselves will lead to bleeding because you are removing fibrin. And the last use is they are given in massive pulmonary embolism. So only 3 main uses of streptokinase like drug is STEMI, ischemic stroke and massive pulmonary embolism. SIM word आपने याद रखना है, ठीक है? SIM word, okay? A STEMI patient was giving L-tiplase, which is a thrombolytic drug. Now, because of thrombolysis or removal of fibrin, now there is some internal bleeding. The patient developed intracranial hemorrhage. Yes, you have removed fibrin. So, the drug which is used to stop this bleeding is antithrombolytics. So, what is the antidote of antithrombolytics? The drug of choice is EACA. So EACA is the drug of choice, but yes, you can use another drug, tranexamic acid. So antithrombolytic drugs are given to stop bleeding due to thrombolytic. EACA stands for epsilon amino caproic acid. Another drug which can be used but it is less effective is tranexamic acid. Okay. Then, which of the following factors reduce oral iron absorption? So, remember, oral iron is given for the treatment of iron deficiency anemia. Remember one rule always that will help you to solve question. When iron is absorbed from GIT, remember iron requires acidic pH for absorption. Iron requires acidic pH for absorption. Can you remember this statement? So tell me, can you tell me the factors that will increase iron absorption? Is vitamin C, because vitamin C is ascorbic acid. That is why we give iron along with vitamin tablets. Can we say proton pump inhibitors will decrease absorption because they will decrease HCl production? Food will also reduce HCl levels in the body because food gets busy with HCl. And tea and coffee also reduce iron absorption because they contain phytates and tannates, which will directly bind with iron and reduce iron absorption. So the answer out here is A, last year MCQ. This was last year MCQ. So which of the following drug is used in iron poisoning in thalassemia patient due to repetitive blood transfusion? So you can see iron is known as Fe. The symbol of iron is Fe. Can you tell me which chelator is having Fe word in it? So D, ferrioxamine word, Fe word aa raha hai. So the answer is D. So let's talk about other chelators. So this is chelator which is given in iron poisoning. So these are metal chelators. BAL, which is known as British anti-leucide, it is also known as dimercaprol. Dimercaprol. Can you tell me why Merck word is coming in this? Dimercaprol or BAL? BAL. Why? It will be the drug of choice in mercury poisoning. So let's write BAL. It is given in BAM. That is your bismuth, arsenic, and mercury poisoning. Calcium disodium EDTA, it is the drug of choice for lead poisoning. Penicillamine, it is the drug of choice for copper poisoning. And we have discussed that copper poisoning is also seen in Wilson's disease. Iron poisoning is commonly seen in thalassemia patient. And a follow-up question, remember, all chelators are orphan drug. All chelators are orphan drugs. This was another question. That means drugs for rare disease are orphan drug. So remember this part always. So this finishes our big topic of renal, cardiovascular system and blood chapter. Thank you very much. I hope you enjoyed. So you can share this PDF and video with your friends also who want to. Yes, BAL is contraindicated in cadmium and iron. We have discussed. Okay, that's great. So thank you very much. This was the previous chapter. You can see the link. So enjoy your day. The exams are approaching. Winter is coming, है ना? So so CVS is an important part. Blood is an important part. Many questions come from this session. Read them properly. Revise them from here. Phosphodiesterase 3 mnemonic. Okay, you want a mnemonic for phosphodiesterase 3 inhibitor. So P for pentoxyphyllene. D for dipyridamole. Third is the which alphabet? C is the third alphabet. C is the third alphabet. Cilostazole. So this is a mnemonic of phosphodiesterase 3 inhibitor. You can see on regular lectures. Okay, regular lectures. Okay, Amrita ji, you need motivation. I would say take a big loan, take money from the bank. You will start working hard because you have something to seek. Now, beta, that was a joke apart. Remember, motivation, you students are so intelligent people that you have already cleared MBBS. You don't have anything else to prove in life. First thing, remember, you are pretty intelligent people. You have already cleared your toughest exam of MBBS entrance. Now you are appearing for another exam. Now you are much more mature also. The only thing you require is a little bit of discipline in life. That, sir, I have to. Discipline means be consistent. Because to clear your MD exam or FMG exam, remember there is a lot of things you have to read. And some things you have to read again and again. So if you're not consistent, you're not reading every day, you will lose interest in medical field. Even if you will read 1 hour a day, the interest will keep you going. If you find your field, if you find your studies interesting, that is the best motivation for you. I won't say you that after clearing MD you will become God, you will receive a Nobel Prize. These are all worldly matters. No, what you are reading is you are reading for your own knowledge. You are expanding your own knowledge. You are reading anything, you are learning anything. It's not for any titles of doctor and you get this. No, read it like it's a journey. Enjoy it. If you're not enjoying these things, very difficult to survive in medicine. Okay, enjoy it. I know it is tough. Remember why you don't forget your name. You don't forget your name because you pronounce it again and again. Second thing, you're forgetting the names of drug, but you don't forget Sayara movie. Sayara movie देखी है? The big, the I think it is one of the movie which should be removed from human history also. So why we don't forget any movie, a 3 hour movie? Because the movie has stories. Movies have emotions. They keep you engaged. So if you read any subject like a story, and you feel the emotions behind this drug, let's say we are having a lecture, if you feel a connect, if you feel the emotion with your subjects you are reading, remember that will imprint in your body or in your mind for very long duration of time. If you are reading for the first time, give some time to read. Okay, don't be in any type of hurry. Your life is very long. Don't worry, you have plenty of time. What you're reading, read with concepts. If you make your concept strong in the next reading, I will tell you, you will not, after the next reading, you will never forget in life. Okay? Okay? Yeah. Yes. And remember, any exam you are giving, even let's say there is a 1% chance, let's say I'm taking, I hope that you all should clear your exam and you will be clearing with the flying colors. But let's say you are unable to clear your exam. Then what? One exam will not decide your life. Exams is not whole of your life. You have variety of other colors you have to seek in life. If you fail, take a break and start again. You are a kind of a soldier people. You will never say no to things. If the life is not giving you opportunity, you are not getting a rank, a desired rank, you are not qualifying, that doesn't mean you don't have any other attempt. You have an attempt again after 6 months, after 1 year. Prepare again. Okay, what it will happen, only 1 year of life, matlab 1 year you will prepare again, then what? You will become much more wiser, you will become much more mature. That is more important. ठीक है? Don't worry, don't take any type of stress. Exam nahi, apna padho, just read and go to the exam and give exam like just any other day, any other pretty bloody exam, just give it. Okay, give your best. Don't have anxieties, don't think of anything else that this might happen, this might happen. It's all useless things. Okay, just be focused. Just give any exam, any NEET exam, FMG exam, INICT exam, just like any other regular exam. Okay, just give like this. And after exam, do watch Sayyara movie. Okay, because we have felt trauma. Why you should not people feel that trauma? Okay, chalo, best wishes. Okay, chale, best wishes, keep learning. I'll share the PDF.